We're kicking off day 2 of the CRI Virtual Immunotherapy Patient Summit with our panel discussing understanding and overcoming barriers to accessing cancer care. Joining us is Dr. Joseph Ravenel, an associate professor in the Departments of Public Health and the Department of Medicine at the NYU Grossman School of Medicine in New York City, where he is also the Associate Dean for Diversity and Inclusion. There, he studies and works to address racial, ethnic, socioeconomic, and other barriers to cancer treatment and preventative services. We are delighted Dr. Ravenel is here with us to discuss how these barriers affect underrepresented communities and share advice on how you or your loved one can make yourselves aware of these barriers and how to overcome them. Joining him are 2 patients who will share their personal experiences encountering these barriers and how they didn't let that stop them from accessing the very best cancer care. Let's get right to our panel.
Thank you, Tamron, and thank you to the Cancer Research Institute for this opportunity to talk about an incredibly important topic, understanding and overcoming barriers to accessing cancer care. This panel is going to address racial, ethnic, and socioeconomic factors that impact access to information about cancer immunotherapy and cancer care, building community trust, and the need to increase diversity among clinical trial participants. I am Dr. Joseph Ravenel. I am an associate professor of medicine and population health at NYU Grossman School of Medicine. I'm also a cancer health equity researcher, and I am honored to be joined by 4 terrific panelists who are going to help us talk about understanding and overcoming barriers to accessing cancer care. I'm going to have each of our panelists introduce themselves, tell us a little bit about their background and why they're so passionate about this area, and then we'll jump right into this topic. And so, joining us today, we have Latoya Bowles Johnson, Stephen Estrada, and Dr. Ana Velasquez Mañana. And so, thank you for joining us today. And I'm going to ask Latoya to introduce herself and tell us why you're so passionate about this area.
Absolutely. Good morning, and thank you for having me here. Thank you to the Cancer Research Institute, and thank you, Ms. Tamron Hall, as well. My name, again, is Latoya Bowles Johnson. I am a physician associate in emergency medicine. I've been practicing in the ER for about 10 years now. I am a proud graduate of 2 HBCUs, respectively Prairie View A&M University, as well as the Howard University, where I obtained my physician assistant degree. And I am a mother and wife of 3 little girls. I was actually diagnosed with stage 3C triple negative breast cancer, invasive ductal carcinoma last year at the age of 36 years old with no known family history. I have become a patient advocate, and I have also been advocating as a healthcare provider as well as now a patient advocate, and helping to just really bridge the gap between the healthcare provider community and now able to bring my perspectives as a patient as well, and helping to break down the disparities and the barriers that are affected with those, and helping to bridge the gap between me being an HCP and representing that community, but it's also representing the patient care community. I'm still in active treatment in a clinical trial, and I'm just happy to be here and to share my story and continue the advocacy work. Thank you.
Thank you so much, Latoya, for sharing with us and for being here today. Definitely look forward to hearing more from you later on. Next, Stephen Estrada. Thank you for being here today, and if you can just tell us a little bit about yourself and why you're passionate about this area of overcoming barriers to accessing cancer care.
Absolutely. Thank you so much, and thank you CRI for having this panel, and everyone for attending. I'm Stephen Estrada, a stage 4 colorectal cancer survivor. I also have Lynch syndrome. Um, I was diagnosed when I was 28 years old and was given a 1% chance to live. The cancer had spread to my mesentery and kind of became involved in too many structures. So I went through standard chemo. I went through a right hemicolectomy. I went through a nanoknife procedure. I went through the whole array of things I could do to try to save my life. Unfortunately, nothing worked. But then I came upon an immunotherapy trial, um, and I spent about 5 years on that trial. And 3.5 of those years I was spent no evidence of disease. Uh, I'm now 36, so it's been a while, but I'm still no evidence of disease. So it's been a literal lifesaver for me. During my treatment, I paired up with the Colorectal Cancer Alliance, where I served as community engagement manager. But I also headed up the diversity and inclusion task force. So I really got to start to see the inequities in healthcare and the barriers to access, and it became very apparent to me that I wanted to lend my voice to that cause. So I'm very, very excited to be here, and I hope that we can all have a great discussion today. Thanks for having me.
Thank you so much, Stephen. We definitely look forward to hearing more from you. And our final guest is Dr. Ana Velasquez Mañana. Anna, if you wouldn't mind telling us a little bit about yourself and why you're so passionate about this topic today.
Of course. I am Ana Velasquez Mañana. I am a medical oncologist. I particularly treat lung cancers at the University of California, San Francisco, and I proudly work in the San Francisco City Safety Net Hospital, San Francisco General. I am originally from Puerto Rico, and I am also a proud graduate of the Universidad de Puerto Rico, which is, the number one medical school that produces Latino physicians. And as one of the very few Latino oncologists that exist in this country, I am extremely passionate about one, diversifying our workforce, trying to decrease many of the barriers that our patients face, and also identifying ways in which we can try to bring more of that high value quality care that we provide on the big academic centers to patients who are in underserved settings. And that's one of the big reasons why I work in a safety net hospital and try to come up with ways in which we can increase access to care for patients who have many different needs and reasons to why they're not receiving the care that they deserve.
Thank you so much, Anna. And so we're going to jump right into the conversation here and just start to talk about healthcare in equity. And so, can each of you talk about sort of your view on cancer health in equity and which communities are most affected by it? And I can, certainly start by talking about my experience working in cancer health equity. I have worked specifically with Black men around colorectal cancer screening. We know that Black men have the highest incidence and mortality from colorectal cancer, and that's largely due to lack of timely screening. There are unfortunately so many barriers to not only men but men and women of color getting timely screening. Have focused on colorectal cancer, but we know that that is the story with so many other cancers. And so Latoya, can you talk a little bit about your view on cancer health equity and which communities are most affected by it?
Absolutely. Well, as mentioned, I am a current breast cancer thriver. And in the breast cancer space, overall, the incidence rate is actually higher amongst white women for developing breast cancer. 1 in 8 women are diagnosed with breast cancer in their lifetime. However, the mortality rate is the highest amongst Black women. There's a 41% higher mortality rate that is associated with Black women dying from breast cancer versus white women. White and Black women, we are only represented in about 3% of clinical trials and clinical research to help us develop the latest and greatest medications for breast cancer. Women under the age of 40, such as myself, have a higher incidence rate, 3 times more likely to develop triple negative breast cancer, which is the most aggressive form of breast cancer. Women under the age of 30 are in addition to that, are being diagnosed at a higher rate than any other group of women with triple negative breast cancer as well. So it is this, the breast cancer is more deadly against Black women, and it certainly shows that there's a huge disparity and there's a huge inequity that is affecting Black women, that is killing Black women from at alarming rates from breast cancer.
Thank you so much, Latoya, for making those really important points and highlighting the fact that even though even though white women have an equal, if not higher, prevalence, that Black women are much more likely to die from it. And you mentioned one of the key reasons, which is the higher occurrence of triple negative breast cancer. I wonder, Anna, can you talk to us a little bit about what Latoya mentioned about triple negative breast cancer, and maybe shed some additional insight on why Black women are twice as likely to die compared to white women from breast cancer?
Yeah. So we know that triple negative breast cancer unfortunately tends to be a more aggressive subtype between the types of breast cancer. The breast cancer has been categorized in bigger buckets over time, has been related to the expression of some hormone receptors or also something called HER2, which is a particular protein on cancer cells. And triple negative breast cancer does not have any of those expressors. So it tends to be a cancer that is not related to hormones like estrogen or progesterone, which we have think historically most breast cancers are too. Um, the causes of why it's more prevalent among Black women is actually still things that are being studied. And there's research ongoing trying to identify if there are genetic ancestry traits that may lead to more higher incidence and risk. I know that there's several studies ongoing because we see similar higher rates of triple negative breast cancer actually in countries in Africa. So it's thought that potentially related to ancestry, but that's still an evolving phase.
Thank you so much, Anna. And so we have been, and so I talked a little bit about the challenge of colorectal cancer in Black men. Latoya just talked about the challenges around breast cancer in Black women. Stephen, I wonder, can you give us some insight on cancer health equity within the Hispanic or Latino community?
So, while my last name is Estrada, I present very Caucasian. So, it would be a little out of my element to discuss any of the health equities that I personally experienced because I did not experience them in the ways that my Latino and Latinx brothers and sisters might have. However, I think that I'd be more useful in this discussion to talk more about the LGBTQI plus community and the the barrier to health access that we actually face. A lot of it comes from the systemic homophobia that exists within our hospital systems and healthcare system. I have dozens upon dozens of anecdotal stories from trans friends who are afraid to even go to the doctor just because of the general lack of understanding, the transphobia. So just that alone creates a huge, I think, mistrust of the medical system, as well as a huge barrier. I think to kind of continue on, it's not just the healthcare system. It's being open and honest about one's health when they're trying to be open and honest about who they are as a person. There's a lot of people who are afraid to come out, and whether that means they're talking about, if they're going to go to the doctor and talk about, let's get a colonoscopy. A lot of things I heard from my community and from actually the Black community when I was, kind of working there, was that people didn't really want to talk about colonoscopies because it kind of came off as gay. And that was something that, a lot of people just didn't want to be labeled as, they didn't want to talk about it. And so it's kind of out of sight, out of mind. So I think that there's a lot of parallels to each of our communities. And it'll be interesting to see what other ones we can kind of line up as this discussion continues.
Thank you so much, Stephen, and I appreciate the uh, recognition, and you certainly highlight an important point that someone's last name does not always connote the experience that they live, and so pardon my presumption, and I really appreciate the
Not at
correction.
all.
Um, and you did a great job of highlighting really important disparities that we don't talk about enough, which is cancer disparities within the LGBTQ plus community, and for the reasons that you mentioned, there are I think those are those are augmented by the fact that we don't collect enough data about sexual orientation and gender identity within medicine generally, but I think particularly with regard to cancer care, both screening and treatment, and so I definitely appreciate you talking about some of the negative experiences that some LGBTQ plus folks can have, and we definitely need to do a better job for sure. Anna, I wonder, do you have any insights either on health disparities within the LGBTQ plus community with regard to cancer, and or I know that you've done a ton of work and research specifically on cancer within the Hispanic or Latino community, and so please feel free to share any insights you have.
Yeah, of course. I definitely agree, and thanks, Stephen, for bringing his insights. I think a big component is the stigma, and because there's been so much stigma surrounding even approaching how to ask questions, and the inappropriateness in the healthcare system of how we ask questions or address people or not ask them what their pronouns are and how do they prefer their identities being identified, that we are centuries behind on where we should be moving forward, particularly with creating guidelines to identify and screen patients who may be from the trans community for cancers that are common, but they are just not being addressed on a day-to-day basis in healthcare, neither in primary care, oncology, or others. So we have a complete lack of knowledge and complete lack, not, I mean, honestly, not really lack of knowledge and awareness among providers, which most can be from stigma or denial. Not really lack of knowledge that the patients have the needs that we know, but we're failing at providing it. In terms of the Latino community, um, the barriers to care are really complex. I think similar to other communities of color, like Black patients, Latino patients get care in low resource settings. They tend to live in communities that are of lower income and poor, higher exposure to pollutants. We know that that causes cancer. Lower number of healthcare facilities, and those that exist are probably overwhelmed and unable to provide the best quality of care or have clinical trials. And to add to all of those barriers, then we have to include things like language being a major barrier for many Latinos in this country. And while our younger generations tend to be, raised Mexican or other types of Latino Americans who may be English proficient, older generations still are primarily Spanish speaking monolingual. Um, And finally, I'll add, the perspective also of a nationality. And from a political and legal standpoint, there are still many areas in the United States in which our Latino um, families and communities are scared to seek care. They don't know if ICE or some other governmental agency is going to be called. They don't know if they can access care. Some of them may not be able to get healthcare insurance because of that. So all of those layers compound into one, the mistrust of the healthcare system, and also the inability to actually access care. If you can't speak the language with any providers, people are not calling an interpreter for you. And then on top of that, you're scared that you're going to get, the police or somebody else called. So we see lack of seeking primary care, and a lot of people unfortunately also seeking the emergency room as their main source of healthcare. So obviously then you're going to see delays in how patients are diagnosed and more presentation of advanced stages of cancer.
Wow, thank you so much, Anna. Those points are so important for so many people, and so and I appreciate the insights that all three of you have shared, and I wonder before we sort of move on to talking about what we can do to actually address some of the barriers that we have all talked about. Um, I wonder if you can provide insight on why health inequity is suddenly something that healthcare and pharmaceutical industries care about. Why do we think now? It's even though we know that these issues have been with us, for those of us who are in these communities and those of us who do work in this space, we have always known that these challenges exist. Why do we think all of a sudden that the sort of larger public the larger public cares? Latoya, we'll start with you.
Yes, I think that this really stemmed in 2020 with the George Floyd incident. That's what really, marked it all. Him being a martyr for the community, unknowingly. But I think that's when we finally got some attention about just systemic racism as a whole, but also it trickled over into medical racism as well. And like you said, these injustices have been practiced against our communities for centuries. So this is not anything new. It's just that incident where the whole world could see a police officer bending on his neck and ultimately asphyxiating him into his death in plain sight. That is what stemmed it all, in my opinion. And so it's very unfortunate that that incident had to occur, but these incidents have occurred, for many, many, many years with or without recordings. It's just that that is what really sparked the nation, the world. And that's what really got attention that trickled down into medical facilities and different institutions. That's when you started seeing more DEI promoted with different companies as well as hospitals. That's when you started seeing a push towards, even with the FDA recognizing that, we should definitely require certain ethnic groups to be part of clinical trials. Because I can personally attest that I was never offered a clinical trial, never offered a clinical trial. And it was really a slap in the face with me being in the medical community myself. But it just made me realize at the end of the day, you're still a Black woman. And so I had to advocate, I had to push, and I had to ask for a clinical trial, as well as divorcing my first oncologist who withheld life saving immunotherapy from my treatment. So, in my opinion, going back to the original question, George Floyd is what sparked this.
Thank you for sharing that, Latoya, and I completely agree with you that was definitely a a a course changing moment I think, for all of us, certainly broadly, but I think you're absolutely right. In medicine, it absolutely was, and I also appreciate you sharing your experience as a healthcare professional. Unfortunately, having the experience that I think many of us have had, that even as professionals, once we become patients, that we're still subject to the challenges around racism, and being in the healthcare profession does not make us immune to experiencing those challenges. And so I really appreciate you sharing. Stephen, any insights on why health equity matters now?
Honestly, I thought Latoya just blew it out of the water. That was exactly what I was thinking. We're in the age of Black Lives Matter and Say Their Names and Me Too, and so it's just we're in this whole movement of seeking out the injustices and the inequities and bringing them to the forefront. And I think that the Black community has been mistreated for so long that when it was finally when we're all stuck inside watching TV and it was in our face, we had to face the reality that this is a very unfair country to the Black community. And then we looked even further and realized it's actually very unfair to a lot of communities. I would like to say, Latoya, like when you were talking about, your first oncologist and having to divorce them, I mean, I had to do the exact same thing. And so I just have to commend you on what you did to save your own life. But when you said, it made me realize that I am, a doctor, but I'm a Black woman to these people. I mean, I can imagine the amount of people who feel that exact same way and who don't have the knowledge that you do. And so I'm hoping that someone watches this and sees this discussion and is like, I see Latoya in me and I can do this too. So just, I mean, that was awesome.
Right, right. Absolutely.
Absolutely. I
Mhm.
I completely agree. And thank you, Stephen. Anna, any insights to add?
I mean, I 100% agree, and I think Latoya framed it perfectly. I think that the fact that the death of George Floyd happened is a shame in our history, that we needed to allow so many years in that event to occur for people to all of a sudden care. I really hope that this wokeness and focus on DEI is not limited, and that people really change their mind shift into acknowledging things, justices, and taking them into account in everything they're doing, always moving forward. I think that the fact that the COVID pandemic was happening at that point, and like Steven said, we were all stuck in our houses and actually saw it, really didn't allow people to ignore it. And I think that also helped, because we were seeing our people get sick. We were seeing communities of color disproportionately get COVID, die of COVID. And on top of that, the police is murdering a Black man on TV. So I really think that that moment was, the drop that um, whatever the saying is, may overflowed the cup, in which people actually started caring about. Um, to your comment on clinical trials, and I really, really, really want, I'm a medical oncologist, and this is why I'm going to say this. I really think that all patients should get a second opinion if they're, even if they're happy and love their oncologist, because there's so many nuances and differences on how a person may approach a treatment of a cancer diagnosis, the staging, and the resources or trials that may be available at X clinic or institution or X hospital. So anyone should feel empowered as a patient to ask for a referral to go see a second opinion, or Google for an institution that is close to you that you can do it. And if you have the resources, and hopefully your insurance should cover it, you should go and get it. Because at least that will happen is that you'll learn something and meet somebody new, and potentially you may go back to your prior oncologist and continue with the plan with they agree. But if not, you found out something that is completely new and different. And there's this misconception that the oncologist is going to get mad at you, or that we may hurt somebody's feelings, or that I don't know if the insurance is going to cover it. Just ask and go. This is your right as a patient to have and to see and to gain all of the information that you actually need to make informed decisions about your care.
Yeah. And may I add something to that
Yes,
comment?
please.
I'm sorry. Dr. Velasquez Manana, actually in my initial diagnosis, I actually received three opinions, and none of the breast oncologists, mentioned clinical trials. So it's just really baffling to me. It wasn't until I actually found the fourth oncologist after I had completed the first course of neoadjuvant chemotherapy, who was a woman of color from the West Indies, and that's when I actually got into a clinical trial because we did have a discussion about it. She knew why it was coming to her, and so I hate to say it, but I mean, it shouldn't matter that your provider should share the same skin color as you, but she does. She is a brown woman like myself. And the other physicians that I had seen before were Asian and Caucasian. None of them had considered me for a clinical trial, mentioned it, didn't even mention immunotherapy, which was the latest and greatest medication at that time for my specific disease. And so it representation matters. And I'm not saying that you should only go to a provider that shares your same skin color, because there are great providers out here who do not care about skin color and do not, own those prejudices. But that is exactly what happened to me. And it was a real big slap in the face, so to speak. And, I just wanted to point that out, that, yeah, I agree with you that it's your life at the end of the day. You shouldn't feel intimidated by the fact that someone sitting before you has MD or DO behind their name. At the end of the day, it's your body. You're in charge of your body, and you're going to do what's best for you at the end of the day. And if something doesn't feel right, say something. Advocate for yourself. Keep pushing, because had that not happened with me, I probably wouldn't be sitting here in front of you right now, because I was misdiagnosed. So, I'm a strong person to say that advocate for yourself and
Thank
keep
you.
pushing until you find the most appropriate answer. Thank you.
Thank you, Latoya, for those insights and for sharing your story. And thank you, Anna, for just highlighting the importance of seeking multiple opinions, and also for highlighting this incredibly important topic of cancer clinical trials, where we know that people of color are underrepresented in those trials. We also know that clinical trials are a critical way that people of color and that those who are socioeconomically disadvantaged can get access to cutting edge therapy like immunotherapy. And so I wonder if Stephen or Anna, if or Latoya, can you talk about your experience with cancer clinical trials, and sort of how you ultimately, to Stephen and Latoya, sort of as patients, sort of how you became aware of cancer clinical trials, and sort of what does it look like for patients who are trying to get who may benefit, who are looking for access to clinical trials. And we can start with Stephen.
So I believe, like Latoya, that everyone should have a second opinion, a third opinion, as many opinions as you want, because at the end of the day, it is your life, and who cares if you're hurting someone else's feelings by going to someone else? I fired my first oncologist because, a lot like Latoya's oncologist, immunotherapy was not presented to me. I was being treated like a standard case of colorectal cancer when I was really 28, which is anything but standard. So um, I really needed to find a different answer. And I think that for your general person who doesn't know anything about cancer or the medical field, which I very much was at the time. Um, before you become your own advocate, you need to know what an advocate is. And so I think linking up with support groups, linking up with places like CRI and their clinical trial finder, I think that those are all very important tools. But one thing that keeps kind of flagging, and I would like to say it just before we run out of time, and I can't. Um, I'm sitting here listening to all these stories, and you guys are so well spoken and have so much knowledge. And as a patient, survivor, patient advocate, I'm sitting here thinking, wow, I have a very solid, above average understanding of this whole cancer thing, but you guys are so smart. And I think that highlights the point that the people in the communities we're trying to reach aren't hearing our message because we're not going down to, and we're not communicating with them the way that they need to be communicated with. I love that CRI gives these platforms, but I wonder how long are they going to watch it if they don't understand what we're saying? So I think that highlights not just panels like this, but the literature that we're giving out in oncology offices. When I was at the Colorectal Cancer Alliance, we would give you would give these little one sheets or little facts for people to review, and I'd read some and I'd be like, "Who wrote this? A doctor? Yeah, they sure did." And I didn't understand any of it. So it's like I think we need to start looking at how we're communicating with our communities. And I think you three being experts in your own fields, I think that's a huge takeaway maybe for this from this panel is communicating with the way people need to be communicated with to get the message across. Otherwise, we should just be talking to each other and that's it. Um, but in that same vein, I think that going back to your question, finding an advocate, a research assistant at your hospital, going to CRI or the Colorectal Cancer Alliances or Komen's clinical trial finders, there's always an answer out there for patients if they look hard enough. But remember, it is your own life, and no one's going to fight harder to save it than you are.
Thank you so much, Stephen. You absolutely nailed it. And what you said reminds me of an incredible mentor of mine who said uh, uh, the reason that more minoritized patients don't participate in clinical trials is because we don't communicate to them exactly what we want them to do. And so that it absolutely underscores the point that you made, Stephen. And I just want to give Anna and Latoya the opportunity to lend insight to that and to maybe also talk about things that we can do to sort of bridge the communication gap.
I 100% agree. I think that one of the main things is trying to guide patients also and be aware of where can you even find these support groups and advocacy groups. And by Googling, you can do so. There's tons of them in Facebook and in social media. I'm a lung cancer doctor, and in lung cancer, we have tons of amazing advocacy groups that are leading research and fundraising to provide grants for researchers to create new drugs, because there's so many different genetic subsets of lung cancer and we see the same exact disparities. I think that we have to come up with ways in which we're able to educate communities more effectively. And that goes from engaging with community organizations, going and participating, in local health fairs, to, being on the media that the communities actually watch. So having
Mm.
going into, if it is Univision for the Latino community or Telemundo, that is the place in which we need to be having some of these conversations. It's not on a major, English speaking TV outlet or in our just journals from scientific journals. If we want communities to have access to information and education and come to us, we need to be doing outreach on the places that they are actually reading, that they're actually looking or listening for, and meeting people where they are. Um, so those are my initial thoughts. And from a trials perspective, I think the one the sponsors and the scientists that are designing trials need to really take into account patient perspective, and I see a lot of of them doing those, in bringing patient advocates and patients to look at how the trial is designed. What are the outcomes? What are the procedures? If you're asking people to get 3 biopsies and blood draws every day for a month, nobody's going to sign up into that trial, right? So we have to make sure that they are trials that are actually patient friendly and helpful, and to have outcomes that you care about. And the other parts are that a lot of these are housed in places where patients do not get care. So we need to be able to find how to make them happen either at home or in community settings, and have also research staff that is able to connect with the patient. It's going to take a long time for us to diversify the doctors and the nurse practitioners and the physician assistants, and that should still be our goal. But we know that it's a lot easier, for example, to get clinical research coordinators and other staff that are ancillary in our clinics that look like the patients, that speak the language. And we should do both of those things concurrently to actually increase equity.
Terrific. Thank you so much, Anna. And we at our hospital, we I think have a wonderful resource, which is patient navigators, who not only help to navigate patients through the system, but also to ensure that what Latoya and Stephen have talked about doesn't happen, which is to make sure that the patients actually know about and hear about cancer clinical trials, and not only hear about it, but hear about it in a way that they can actually understand. And so I wonder, as we are coming to the end of our session, and boy, that time went by really fast. But I wonder if each of you can give us some closing remarks about this topic, and about essentially, what you think we can do next, or better, to actually advance cancer health equity, particularly when it comes to immunotherapy for the communities that we've been talking about. So if each of you could maybe give us about a minute of closing comments, and let's start with Latoya.
Absolutely, yes. I just wanted to say, in relation to the last question that you asked, in reference to clinical trials, like I said, I was never asked, I was never offered. It was about 60 or 65% of Black women who were surveyed who were never offered, clinical trial, and all of them agreed that they would consider a clinical trial. So the first step is that we need to do better by asking every single patient. And if we need to educate them, and it's not the responsibility, just it doesn't just fall on the physician. There's clinical trial liaisons, nurse navigators, or whatnot. I had a nurse navigator, but she never offered me a clinical trial. And so we really need to get into the mind frame of actually offering a clinical trial and educating, as we call each other in our breast cancer community, we call each other breasties. And you can definitely find the clinical trial finder with Cancer Research Institute in life-saving immunotherapy trials. And I've also partnered with another group called, the Black Breast Cancer Alliance, Touch, and they founded a movement called When We Trial, and we've already signed up over 4,100 Black women into clinical trials, and so that's another resource that you can use, and there's information there that's relatable to you. It's not information that's over your head where you can't understand it. It's developed by Black breasties for Black breasties, and so that is very important that you are informed of what's going on and know that clinical trials, you're not just going to receive a sugar pill, that you're actually going to receive standard of care, and you're actually going to receive the latest and greatest medication for your disease. Clinical trials actually, sustain lives. As Stephen has said, he's here because of a clinical trial. And so it's very important that people acknowledge and know that, and just really advocate for yourself. If you feel something, say something. That is the most important piece of information that I can leave you with. Thank you.
Thank you, Latoya. Stephen.
So, Latoya, once again, just kind of hits everything that I really wanted to say. I think that in order to start increasing the diversity, within clinical trials and just starting to level out the disparities that we're seeing, is really through education. It's really through communication. It's through going out into the communities, meeting them where they're at. Um, as far as clinical trials go, like CRI has a wonderful clinical trial finder. Patient navigators. I myself am a certified patient navigator, um, and it's a very rewarding, very tough job. But know that when you're hooked up with a patient navigator, it's because they want to help you. And so the more you tell them what your wishes are, whether it's quality of life, whether it's quantity, whether it's clinical trials, standard of care, there's always someone there to listen to you, and it's usually your nurses or your navigator. Um, for people who are affected by colorectal cancer, the Colorectal Cancer Alliance has a great tool as well, and certified patient navigators on call for really whatever you need. So I'd like to toss that out there. Um, for my LGBTQI plus brothers and sisters, what makes us different isn't always on our skin. But know that you have every right to have a provider that understands you, that listens to you. And if you feel like you don't have that, you don't have to stay. Second opinions go on and on and on and on. Third, fourth, fifth, sixth. But you have a right to be happy with your care, as we all do. So I'd like to push that out there. Natoya gave a great little mantra. Mine, when I was going through treatment, was you're going to hit a lot of no's, but just keep going because you're going to find your yes. And I found my yes, and it saved my life. So I encourage you to do the same. Thank you, CRI, for having me, and thank my awesome panelists. You guys were fantastic. What an honor it was to be with you this morning.
And Anna, did you want to have any last words?
Sure. I would say, this is something that I've learned from other patient advocates that I've worked with, and it's the expert on cancer is you because you have to live with it as a patient. It is not your doctor. So we may know the science behind it, but we don't know what it feels like. We do not know what the treatment is doing to your body. So use your voice and know that you are the expert on living with this disease, and it's your right to advocate for the best care for you, to be happy with the care that you're receiving, to be convinced with the answers that you're getting, and also use that, privilege that you have at the time of having the knowledge of being participating on a trial or doing other things, to educate other patients who may not right now, be scared. And I think a lot the people that we have in this call clearly have shown us how they do that on a day-to-day basis, and to also advocate with our policymakers, because at the end of the day, trials happen because there's money that goes to research. Money is determined by the government. Trials, healthcare systems and access depends on insurance, and all of that is related to the government. So how we speak with our politicians, how we elect them, really impacts our care.
Thank you, Anna. Thank you, Latoya. Thank you,
Thank you.
Stephen. And thank you, CRI, for this incredible opportunity. And thank you to our audience. Take care, everyone.